Hi, welcome to Keto Life Support, where we make your keto life sustainable, fun, and low stress. I'm Kim Howerton from theketonis.com, and I'll be coming to you weekly with some of my keto besties to bring you the practical, real-world keto advice that you need. Quick disclaimer, I am not a doctor, and even if we have a doctor in the house, he or she is not your doctor, and nothing on this show should be taken as medical advice. Always check with a trusted medical professional about your personal medical concerns. Hey, Dr. B, how's it going?
Hey, it's great. How's it going?
I'm doing pretty good today. I feel happy that we're doing this.
Yes, it's good to see you again. You look great. You must be carnivore again.
I am. Well, actually, I found that I can squidge at the edges a little bit, but in very specific ways. So I've really decided this round of carnivore to kind of define some of my, edges that I can and can't go over. And so that's been really good for me because there was a way that I'm a rebel. I don't like to be too constrained. So I kind of want to know where I can go and where I can't.
Absolutely. So. Yep. I love it. It looks good on you. So keep it up.
I appreciate that. Thank you. Yes, it is. Vanity is a fabulous motivator, right?
Yes.
I kind of feel worse. I mean, it's kind of weird to say this, but I almost feel worse for the skinny people with diabetes. Cause they don't have the physical indicators until they're really sick. Nobody thinks anything is wrong with them.
Exactly. Yeah. Yes. Nisha's adjusting my light for me.
Okay, good. You gotta, look just right. So I wanted to ask you before we jump in, because I was thinking about this today. I know that one of your main motivators for doing keto and preaching about keto and prescribing it is the diabetes epidemic. Is that the case?
Yeah, that's a huge motivation for me. A couple of years back, the Tennessean, which is the main newspaper in Nashville, Tennessee, came out with a ranking of the 99 counties in Tennessee and the health ranking. And my county was not the very least healthy, but it was in the bottom 3. And that's been a few years back. And I was like, you know what? Screw that. I'm done with this. There's no way that I'm just not okay with that. Cause first of all, it looks bad on me. Right? Cause I'm the doc in this county. And I thought, yeah, I've got to change this. I don't know how I'm going to do it, but I've got to fix this. So I started out trying to reverse the health in my own county. And then that morphed into the state and then now the world. I'm really pissed off that there is a diabetes epidemic in the world. Yeah. Type 2 diabetes is completely preventable and completely reversible, yet it is 90% of the diabetes in the country. That's what 9 out of 10 cases are type 2. And it's what? I mean, that's Twilight Zone material.
Totally.
Right? Totally. It's completely reversible, but it's actually now more common in the U.S. to have diabetes or pre-diabetes, which is basically just stage 1 diabetes. I think you and I were talking about that.
Right.
Than
it is diabetes,
not. Yeah, it's weird. It's weird in the U.S. to not have diabetes. What?
Right.
You're now a weirdo if you don't have diabetes. And so you and I are weirdos now. We're not average. Well, we knew that already.
We're crazier than average. Anyway, it's nuts. I've been, one of the things, I grew up in a very different environment than you live in, right? I grew up in Berkeley, California. I was probably the fattest person in most rooms that I was in when I was younger, right? And not to say that there aren't sick, diabetic, all that in California, but it tends to have a sheen, a veneer of health, over it. And people take a lot of pride in not being overweight and, this and that. And so it wasn't actually until I got into the keto sphere that I realized that type 2 diabetes was such a big problem. I feel like I was like, how did I not know this?
Yep.
But I didn't realize how huge a thing it was in the world.
Yeah. And it's not a sin that you didn't realize that.
Yeah.
The sin is that most family medicine doctors and internal medicine doctors and pediatricians don't realize it either.
Yeah.
That's the true sin, because when they check your routine annual labs, they don't check an A1C or a C-peptide. They have no idea if you're pre-diabetic or not. And so I think that's why this epidemic has been allowed to sneak up on us, is because nobody was checking for it.
Nobody. And not to mention that so many doctors have no idea what insulin has to do with anything. I mean, I remember hearing about somebody who said, like, when they asked their doctor to give them a fasting insulin test, they were like, "What? You mean the medication for type 1 diabetics?" Like, they didn't have any concept.
Yeah. And I'm laughing only out of irony, because it's embarrassing that there are so many doctors out there like, why you want to check a fasting insulin? What's that got to do with anything?
Right.
Yeah.
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 Yeah. Like Dr. Kraft, when was that? The 70s? I should know, but I don't know.
Yes.
And it's like nobody paid any attention.
Yeah, it's ridiculous. His book's on my nightstand right now. I'm rereading it for the 8th time.
I have to read that. I haven't read it. I've certainly looked at a lot of the study, but I haven't anyway. People, write in your questions, but hold them until I say, please give us your questions, because they'll go by and then I won't see them. So, one of my clients wrote me a message today, and I'm just going to read a couple excerpts from it. Sure. I had my doctor's appointment today. I've lost 7 pounds over the last 2 months since I went keto. I'm just getting to it. I was prescribed metformin, but I can't take it because I have terrible side effects. 3 months ago, A1C was 6.1. Doesn't know what it is, just got retested, so is looking at, but has been keto for 2 months. But today her doctor suggested a drug called Saxenda, to help her lose weight is what they suggested. And, this person actually has hypothyroidism and is on medication for that, which I know is an issue potentially as well. And she's really concerned because she wants to fix these issues with keto, is not sure about adding all these different prescriptions. And so I wanted to ask you, because I know a little bit about this type of drug, but I wanted to ask you, why is it being prescribed? Should it be prescribed? What does it do? Let's talk about, and we don't know, I guess this is a class of drugs. It's a form of a class. It's a class that's called GLP-1. Is that right?
Yeah, it's glucagon-like peptide 1 receptor agonist or activators. And so they activate a specific receptor for GLP-1. And we have these receptors in the pancreas and other parts of the body, and there's some in the brain as well. And this is a very new class of drug. I think the very first one was Byetta, and it was only FDA approved in 05 or 06. So it's a very new class of drugs. It's a very expensive class of drugs. And Saxenda, I want to get into more detail about how this is a weird thing. But let's talk about your friend some more. First of all, I assume she's obese. That's why they,
overweight, over the weight she wants to be.
Okay.
Yeah.
And so her A1C is definitely high. She's pre-diabetic at this point, but she wants to basically fix the underlying problem. She wants to fix the root cause of this by fixing her diet and her lifestyle. And I applaud her for that. First of all, she has pre-diabetes or stage 1 type 2 diabetes.
Right.
However you want to say that, right? But I love that. I think that's the perfect way to put that, because it makes it sound worse, which is good. You want it to sound bad.
You want to be a little scared here.
Yes, absolutely. She should be scared, and she should want to fix this. And Saxenda is a Band-Aid, a very expensive Band-Aid on this, and we'll get into that more about why that is. And so the GLP-1 agonists are a new class, and there's Byetta, there's Victoza, there's Tanzium, there's Trulicity, Luxemia.
Trulicity is on the TV all the time.
All the time, right. And
all the time.
And now let's talk about, that's a good point. Let's talk about that. So what drugs do Big Pharma, which ones do they advertise on TV? Do you ever see a generic drug advertisement?
No, probably the ones that are expensive.
That's right. If they're top dollar, super expensive, then you're going to see ads every 5 seconds for them, because that's how you sell expensive stuff in the U.S. is to advertise, right? And so they're spending, I mean, and these are ads on prime time, and so they're spending millions of dollars a month advertising this class of drugs. And this class of drugs is very, very expensive. If you had to pay cash, they're anywhere from $750 a month up to $1,500 a month, depending on which one of them and which drug card you got and which insurance.
You could hire a personal chef
and a personal trainer. That's right. That's right. Exactly. Yeah. And somebody to slap your face every time you ate a carb. You could have 3 people on payroll for what you would pay for these drugs. And they're all injectable. They're all very new. They all have a black box warning, which we'll talk about in a minute. And I've seen nothing but uniformly, unimpressive results in my patients who come to me on them. And the reason I say that is because I virtually never prescribe these drugs.
Yeah.
Virtually ever. And I'll tell you why later on. But when people come to me, these are one of the very first drugs that I'll say, okay, stop that. You don't need that anymore. When they're eating keto and where they're trying to reverse the root cause problem of what's going on with them, because they're so expensive. And so doctors, the doctor's nurse, the pharmacy reps, everybody's playing reindeer games, trying to get prior approvals, trying to get this discount card to go through, trying to do all this stuff because these drugs literally cost $1,000 a month. You could just say that to for brevity, anywhere from $750 to $1,500 a month. And so, yeah, who can pay $12,000 a year just for one drug? And
that
so you would
may or may not do anything.
And that's exactly right. And so you would expect a drug that's expensive to have near miraculous results on your A1C and on your BMI or your weights. But the problem is what I've seen is that these drugs and the studies show that they'll maybe have a 0.1 to 0.3 reduction in A1C. So if she started this, she's got a 6.1. If she did nothing else and just took this, she might come down to a 6 or a 5.9. And that's what $1,000 a month is going to get her. Right? And so when I was kind of excited about this drug when I first heard about it years back. Oh, that's okay. I get that. That might be really great. But they're stupid expensive. Nobody can afford them. They're tier 3 on every insurance plan, which means the doctor's got to do a prior authorization and fax this again and sign this and fill out this paperwork. And most docs just aren't going to do that these days because we're so pressed for time. But then there's all these discount cards and they're getting charities to pay for it. But I really think there's probably an underlying reason why they're charging this much for these drugs that don't really do much. And why would, we're already in a atmosphere here, big medicine, big pharma, where everything is ridiculously expensive.
Yeah.
And why would you come out with a new class of drugs that's going to be even more expensive that most insurance companies are like, I ain't paying for that. That's not on our plan. So it sounds like they may have an agenda here.
Right.
To just basically, if you break this system, then what's the U.S. going to go to? It's going to go to a single payer system. Then everything gets paid for. And I don't know. I'm just saying it's really weird because we need to be trying to save money in medicine and pharmaceuticals, not trying to break the bank. And these are like grand slam home run, break the bank prices that they're charging for these drugs.
Yeah. Okay. So, my first thoughts on this is that either they know they don't work and they know they're going to get found out, so they might as well make their money now.
Maybe. Yep. That'd be a good strategy.
Or maybe, I can think of a couple other theories, one of which is people in the U.S. tend to think the more expensive something is, the better it is.
Right. And then they've got to get their money back for all the research that they put into these things. And I'm sure they spent hundreds of millions in the research and development phase.
Right.
But at the same time, the drugs they're pitiful. They literally give you a 0.1 or 0.2 reduction in A1C. And I think the research is like over a 6-month period, you maybe lose anywhere from 2 to 6 pounds.
Yeah, I looked it up. 1 to 3 kilograms over 6 months was kind of what the average was, which is for those that don't speak kilograms, about 2 to 6.5 pounds.
Yeah, over 6 months. And so you can immediately go, I can lose way more than that on keto. Why would I pay $1,000 a month? So you pay $6,000 to lose 6 pounds. So you're paying $1,000 a pound to lose the weight with Saxenda, which is one of the GLP-1 agonists. And so,
go ahead.
I'm just wholly unimpressed with the entire class of drugs. They actually work by raising your insulin level. That's how they work. They initiate insulin production in the pancreas. And so they're actually, so really you could just take insulin and it does the same exact thing. Right?
Right. One of the commercials says, use the insulin you already have. I remember that and I was like, wait, I don't know that sounds like a thing we want to encourage in the
But
body.
to them, that sounds good. That's a good marketing point, right? Use the insulin you already make. We'll just help you make more insulin. So hyperinsulinemia is nothing to worry about. Well, wait, what? Yeah, exactly. And so they literally they're thinking with a completely different paradigm than you and I think with about this topic. That's what's going on here. That's why it seems like Twilight Zone-ish. Like, what are you talking about? You're gonna make me produce more insulin, but yet by activating the GLP-1 receptor, you don't get the weight gain. But think about how
so it kind of goes around the back way.
You're gonna have more insulin but not gain weight. Now, how is that gonna come without a price? That just doesn't make physiological sense, right? That doesn't make any sense how that's going to work. They lower glucagon and they also delay gastric emptying. And so basically your food just sits in your stomach longer. And so you can, and so that's healthy. And so, but you can see immediately there's going to be heartburn, there's going to be nausea, there's going to be reflux, there's going to be bloating. All that stuff's going to be very common with these drugs. And in fact, I see that in clinic all the time. Right. And so, but the black box warning that I talked about earlier, they have for people who don't know, if a medication has a black box warning, that means that it might cause a very severe complication that a doctor needs to be aware of and is duty bound to tell the patient about. Now, I guarantee you her provider did not tell her, hey, this might cause thyroid cancer. Guaranteed they didn't say that, right? But that's what black box means, is the doctor's supposed to say, hey, I'm going to give you this. I think the benefits outweigh the risks, but it might cause C-cell cancer in your thyroid.
Right. And I've read potential links to breast cancer as well.
Yep. And I predict that it'll come out, because anything that raises insulin weirdly like this, that's going to increase your risk of cancer. No doubt. Insulin's a growth factor, right? And so I guarantee you 5 or 10 years from now, they'll be like, oh God, there's been a recall on Byetta and Victoza and Saxenda because there's a link with cancer. Watch. And so anybody who's taking one of these, keto and stop taking that after you see your doctor, of course, because Kim and I, we're not giving medical advice. We're just talking.
We are not. We are having a chat about someone I know who brought up a topic. Yep. And we were like, hey, tell me more about this thing.
Right.
Yeah. And it makes one of the things that I was reading as well, because this person mentioned that they have thyroid problems and are on thyroid medication. One of the contraindications on the drug from the drug company is taking thyroid medication. Yep. Because apparently
any thyroid issue, you should not take this drug. That's exactly right. And so, the funny thing is Saxenda is exactly the same drug as Victoza. It's just a higher dose. Okay. So all of the GLP-1 agonists potentially have the weight loss as a potential side effect, but they basically just doubled the dose of Victoza, called it Saxenda, they charge an extra $300 or $500 a month for it. And now Saxenda got the FDA approval for long-term weight management. That's the FDA approval. I think that's how it's worded. And so they're wanting you to take this $1,000 a month drug long term to help control your weight. So they want you to spend $1,000 a month for years to try to get your weight down, even though it's going to cost you $1,000 a pound.
Well, and I mean, is there a potential from a medical standpoint, sorry, let me interject because somebody just wrote in that, some of the other, risk factors for these drugs are, gallbladder diseases and pancreatitis. Somebody just mentioned they were taking it when their pancreas took a dive. So just saying that that's not just the cancers, there are other issues. My question is long term, they're saying this is a weight management system that you take it long term. Is there any potential sort of boomeranging effects when you stop taking it since it engages with your insulin so much?
Oh, absolutely. And no, I guarantee you that, I know it hasn't been studied long term because Saxenda was only FDA approved in probably 2007 or 8. So there cannot possibly be any long term post market research done.
Right.
We've only had at most 12 years of post market, right? And so we have no idea what it's going to do long term. Literally, we have no idea what it's going to do long term. And that makes me very nervous, very uncomfortable. And so when there's a dietary option that's easy and sustainable that does the same thing with none of these black box warnings or potential side effects, I'll go with that every time.
Yeah. I mean, if somebody asked me, Kim, can I be relatively secure that in 6 months of keto I'll lose at least 6 pounds? I would say I would bet good money that we can do better than that.
Unless you're 10 pounds from your goal weight, you're going to lose 6 pounds in 6 months. Bet.
Yeah. So I'm just, anyway, so we now know that you probably aren't going to be prescribing a lot of these drugs, to people. Now, I just had this question because it kind of came up, emotionally for me when I saw this communication was my first instinct was to be mad at her doctor that he would even suggest this crappy drug for this non-necessary use. And then I thought no, let me be a nice person and think he's gotten some bad education. How well in the doctor community, how well is this actually understood?
I guarantee you the only education her provider has gotten is from the drug rep, who's probably very attractive and has probably bought lunch for the clinic staff several times and has brought by a bunch of Saxenda samples to give out. And so, when somebody starts Saxenda, they're going to lose a little weight. That's going to happen. And so immediately this doctor's gotten great feedback from the attractive drug rep. Great even the staff is on board because they've got that really great lunch from Buffalo Wild Wings and they really like this drug rep and I guarantee you there's coupons that they can hand out. You can get the first month for $100 or the first month for whatever. Literally it's like, it's like a car salesman. Yeah. How they do this stuff. It's like, for the first 6 months you have no copay. Well, what about on month 7? What happens? Oh, well, that's up for debate, right? But this doctor, I guarantee you, has never been educated deeply in any meaningful way on any of the GLP-1 agonists. We don't get that. Now, when you go for CME, you might learn about the class as a whole, but Saxenda is kind of a special case because they literally double the dose. And all of the GLP-1 inhibitors are FDA approved for type 2 diabetes. They're all approved for that. Okay. Some of them even got the FDA approval for reduction in cardiovascular event risks, which is a very, what? It's it's a kind of a touchy-feely, but they got FDA approval for that indication to decrease cardiovascular events. And so if you're afraid somebody's going to have a heart attack or a stroke, you can give them this because there was a meta-analysis in JAMA, I think, 2017, 2018. It hasn't been long where they showed a slight reduction in stroke risk if you were on a GLP-1 agonist. And so and so they're going to tout that to the heavens in the advertisements to doctors. They're going to talk about the relative risk reduction, obviously not the absolute risk. And I know, Kim, you know the difference, but a lot of people watching may not know that there's a huge difference between relative risk reduction and absolute risk reduction. And so the drug reps always talk about relative risk reduction, and doctors just hear this big number like, 12%, 15%. when it's really 1.01% of absolute risk reduction or something like that.
Right.
But that one meta-analysis kind of made Saxenda take off after they, and I'm sure, all the reindeer games that get played, getting stuff published and all that kind of stuff. And I guarantee you some of the research was hidden, not published, not talked about. And it's just a mess. Like the actor said, somebody bring a broom because this is a mess.
Got it. Someone has just asked a follow-up, which is, we've discussed metformin before. Metformin has been on the market for a very long time. So it is one of the drugs that we know a lot about potential issues. Do you still prescribe metformin, and when?
Yeah, I do. And it's probably by far the most common medication I'll prescribe for type 2 diabetes because it helps optimize insulin function as the person is taking control of their diet and is starting to eat a very low carb, high healthy fat diet. And don't get me wrong, I don't want you to take any medications, but the metformin is one of the least bad of all of the possible type 2 diabetes medications that you can take.
Yeah, I have a friend who was type 2 diabetic, went keto, is very strongly keto, but continued to take metformin because it's not contraindicated with a low carb diet. Brought his insulin down, his fasting, he brought his glucose down and then brought his insulin down, but his insulin wouldn't go below a certain number. It was still fairly high, like 13, his fasting insulin.
Right.
Stopped taking the metformin for a while, and that fasting insulin actually went up with no change in diet. And so he went back on the metformin because he's like, I think it's keeping me under a slightly better control.
Exactly. And that's exactly what metformin does. It just helps the insulin work better so that your pancreas doesn't have to produce as much insulin, because most people listening to this probably know that high blood sugar is very dangerous and very bad for you.
Yeah.
But chronically high insulin levels are also very detrimental. They're damaging, they're inflammatory. And so you don't want a high blood sugar, but also you don't want to be taking a medicine that's going to give you chronically high insulin levels either. That also leads ultimately to disease.
Right. So contrary to the GLP-1 agonists, which produce more insulin, metformin doesn't produce more insulin. It just helps the insulin do better things.
That's right. It helps it to work better is a good kind of common sense way to think about it.
Got it. Some people, I'm going to reiterate something that Dr. Berry said a few minutes ago. Dr. Berry is a doctor. He's not your doctor. Even if he is your doctor and you're watching this, right now he is not your doctor. And I'm not a doctor. So I cannot give medical advice. Anything that comes out of my mouth is not medical advice.
That's
and in this context, nothing that comes out of Dr. Berry's mouth is medical advice. We are shooting the breeze about some medical topics.
Absolutely. Yeah. And so all of the GLP-1 agonists work by increasing insulin, decreasing glucagon, and delaying gastric emptying. That's just the mechanism of action.
Okay.
But if you look up Saxenda, it says that its mechanism of action is it activates GLP-1 receptors in the brain and it regulates hunger and calorie intake. So it doesn't even mention the insulin and the glucagon. It somehow magically acts in the brain. Even though Victoza is the same exact drug and it works by raising insulin, lowering glucagon, and delaying gastric emptying. So it's like, how can you even get away with these language games? It's the same exact drug. It's just a double dose.
When you double it, it just magically does something completely different.
Yeah. Stops working in the pancreas and just goes straight to the brain if you double it.
Straight to the brain. Yeah.
Okay.
All right. So what, some people were asking about something called Actose. Do you know, what is Actose?
Yeah. And so Actose is another class, pioglitazone and Actose and Avandia, and they raise insulin. The way they work is by raising your insulin level. They cause the pancreas to produce more insulin. They just work by a different mechanism than Victoza and stuff.
Okay, so I'll just ask this. Is there any reason to treat diabetes with a drug that raises insulin?
There is no reason to treat type 2 diabetes
Type 2.
with a drug, that raises insulin levels because here's the thing, most docs don't realize this. And if you ask most docs, you'll say, describe what's going on with glucose and insulin in type 2 diabetes. And every doctor, almost to a man or a woman, will say, well, you've got high blood sugar, right? But the pancreas is just burned out, and so it doesn't produce insulin anymore. And so you have to give somebody Victoza or Actose or insulin so that you can give them more insulin. If a doctor says that, they are ignorant. They do not know what they're talking about, okay? Because for all of my pre-diabetics and type 2 diabetics, I also check a test called C-peptide. Okay? And C-peptide gives you a direct look at how much insulin this person's pancreas is making. And almost without exception, every type 2 diabetic's C-peptide is high, which means they're producing lots of insulin. It's just that they're eating so many damn carbohydrates that the insulin has got nowhere to put the blood sugar that's in the bloodstream. All their cells are already full of sugar, already full of glucose. And so you can raise the insulin as much as you want to. And if all the cells are full of insulin or are full of glucose already, there's nowhere for the insulin to shove it, right? Because what usually happens is when you have insulin, it pushes the glucose into your muscle cells or into your liver. It pushes into cells, gets it out of the bloodstream. And so when you check a blood sugar or a blood glucose level, it looks better. And you're like, oh, good. We're controlling the diabetes. But you didn't make the blood sugar disappear. You just pushed it into the cells. And it's just as damaging there to have too much glucose as it is to have too much glucose in the bloodstream. And so any medication that's given to a type 2 diabetic that works by increasing insulin, it's ridiculous. It's like saying if somebody's drowning and you give them a glass of water. Yeah, it doesn't help them. It's completely counterproductive because you're still causing all the damage. You've just moved the glucose from the bloodstream into the cells. And so instead of damaging the arteries and the arterioles and the capillaries, it's now damaging the mitochondria and the other cell organelles, which is also bad.
I've seen and read and heard that when they treat type 2 diabetics with insulin, it doesn't increase their survivability outcome.
That's right. And there were 2 huge studies done a few years back, and Dr. Jason Fung talks very elegantly about these 2 studies. And what we were trying to do with these studies is we were going to just come down hard on type 2 diabetics, and we were going to be very aggressive with our treatment. We weren't just going to put them on metformin or glucophage and say, okay, just, eat a better diet. We were going to start insulin immediately, right? And start the Actose and the glyburide immediately and drive that, very aggressively, and drive that A1C down and drive their blood sugars down. And what we found was that in one of the studies, they did just as poorly as people that you didn't even do anything for their diabetes. And in another study, they actually did worse.
Wow.
So they had more bad outcomes by doing that. And so the take-home message was not, oh, we shouldn't try to treat type 2 diabetes with aggressive medications. We should treat it with diet. But what doctors heard from those studies for a few years, and I was one of them for a few years, was that, oh, you shouldn't aggressively try to lower A1C. You should just be happy with an A1C of 7 or 7.5. That was the take-home message that doctors took from these studies. Even though these studies very clearly showed that insulin is inappropriate as a therapy for type 2 diabetes, that's not what their findings were at all. Their findings were, oh, you should just be happy with an A1C of 7.5 and not try to lower that aggressively. Right. But they should have found, oh, you shouldn't try to lower it aggressively with medicine. You should try to lower it aggressively with your diet, because that will lower your all-cause mortality and your bad outcomes.
Right, absolutely. I'm just going to take a moment to pause and say, type 1 diabetics, I apologize. I often say diabetes and mean type 2 diabetes. Yes, insulin is required for the treatment of your condition, and I apologize for pretending you don't exist. Okay, moving on. So one of the things I was thinking about that might be going on in the minds of some of these doctors, I'm trying to get into their heads, is I think traditional doctors who don't yet understand what keto can do for a lot of these insulin-related conditions, I think they're frustrated and feel sort of powerless and like they're not doing any good anymore. Like I think there can be this real depression that sets in for some doctors. And so maybe when they hear about these drugs that at least had some positive outcome in some test somewhere, that they like cling to it like a lifeline and don't look at the fact that that's just some top level stuff and underneath it's really dirty.
Yeah, that's absolutely correct, because it's very frustrating to have this big population of type 2 diabetics that just keep getting fatter, keep getting sicker, keep losing legs, going on dialysis. And you're like, I'm powerless. I literally can't do anything about this. And so when a new drug class like this comes out, first of all, the drug reps push it to the heavens and back. Oh, this is it. This is the one. And so doctors are looking for the golden drug that will help them have an effect on their patients' outcomes. And so they were hoping against hope that the GLP-1 agonists were that. Maybe that's it. Maybe this is it.
Yeah.
But it's just the results have been so disappointing that for poor doctors who aren't on board with keto, it's got to be so depressing right now to be a doctor.
Right.
Like I love what I do right now, and I love sharing this message because what I'm saying works, and that's fun. But when back, 10 years ago when I was that guy saying, oh, you need Victoza and you need Actos and you need glucophage and you need to eat more whole grains, it sucked so bad. I can't even tell you how bad it sucked to be a doctor back then, because I was like, it's just, I'm not doing anything. I'm not helping anybody. I'm just making a good salary to say hi to a bunch of people every day and tell them to take another pill, and nothing's getting better. It was very disappointing and very frustrating.
Yeah, I can totally understand that. Dr. David Unwin in the UK, he is this awesome, sprightly man. And he was a GP, I think a GP, and he was like gonna retire because he was miserable because he just kept seeing people get sicker and sicker and sicker. And then he found out about low carb and saw his patients getting better and better. And now he's like, I don't want to retire. This is awesome.
Yeah, it's fun again. Yeah, exactly.
Yeah, absolutely.
I totally agree. Yeah. And I love Unwin. He's a great guy. I can't wait to meet him at one of these events in the near future. Hopefully I'll get to meet him soon.
Yeah, absolutely. His wife's a hoot too, I think. Somebody just commented on the live stream that her doctor was really happy that her A1C was 6.3. Can you dive into a little bit of why doctors seem to think these A1Cs that are out of range are okay?
It all comes from those two big studies. One was the DCCT, right? And then the other one was the Accord study. And so they got every doctor in the country read the conclusion of these studies, right? And so the takeaway message was, it's dangerous to try to aggressively lower A1Cs back to normal. Even though the take-home message should have been, it's dangerous to do it with the drugs you're doing it with.
Right.
It's very safe and very healthy to do it with diet, but it's very dangerous to do it with drugs because all you're doing is just giving them hyperinsulinemia with these drugs or with the insulin. And so many doctors were trained basically, because I used to be one of those, I was aggressive. I was like, oh, we're going to get that A1C down. But then after the Accord and the DCCT trial, I was like, I guess I just need to be happy with a 7. And so for years, I was happy if you had a 6.5 to 7.5. I was like, yeah, that's pretty good. Keep doing what you're doing. I'll see you in 6 months or 3 months or whatever. But I did not know the power of low carb, high healthy fat, ketogenic. I didn't know that there was such a thing back then. And so I didn't have any other method to lower your A1C except with the drugs that work by raising your insulin.
Right. So this came up the other day. Somebody was a little confused between A1C and blood glucose. And so, A1C of 5.7 means that your average blood glucose is somewhere around 120. Is that right?
115, 120. Yeah. And there's actually more than one way to calculate an A1C.
Okay.
And I like using Dr. Bernstein's method of calculation, which actually gives you a more accurate picture, because the other way of calculating it will tell you that a 5.7 is probably 105, 110. And so you think, oh, okay, well, that's not bad, right? And so Yeah, A1C gives you a 3-month average, a rough 3-month
roughly.
average.
Right.
And it can be affected by multiple things. If you're anemic, that can affect it. If you work out hard, that can affect it. If you have, polycythemia vera, hemochromatosis, any of these things that mess with the red blood cell can cause an abnormally high or low A1C. But on average, for the average dude or dudette, an A1C is a great marker of how your diabetes or prediabetes has been doing over the last 3 months. And so because I can check a fasting blood sugar on you, Kim, in my office, and you could be a severe type 2 diabetic with an A1C of 8. And if you haven't eaten in 12 hours, your fasting blood sugar might be normal.
Right.
And so if a doctor only checks your fasting blood sugar once a year and says, yep, everything looks fine, he can miss severe prediabetes or type 2 diabetes and have no idea you even have it and give you this false assumption that you're healthy and that everything you're doing is proper. Keep doing it for another year. And that's the true danger, is if a doctor doesn't check your A1C and your C-peptide, he has no idea if you're a pre-diabetic or a type 2 diabetic or if you have hyperinsulinemia.
Yeah, absolutely. There are multiple tests that you need to keep track of. It's not like when I hear people saying they had a blood glucose test, it was normal, so their doctor refused to give them an A1C. I'm like, that is malpractice.
It's malpractice, absolutely. And so if that person winds up with type 2 diabetes and the doc's like, oh, you have type 2 diabetes now suddenly, they've probably had that for 5 to 10 years and he just didn't catch it, because once your type 2 diabetes gets severe enough, you won't be able to have a normal fasting blood sugar. Even if you fast for 24 hours, it'll still be high enough that he's going to go, ooh, that's pretty high. We better check an A1C.
You're now broken enough that you're broken all the time.
Right. I don't know why doctors don't make an A1C part of their routine annual labs. I do it all the time, and I'd never have insurance kickback about it. I don't know why docs are so hesitant and so bullheaded about checking an A1C. I mean, it's going to give you more information about your patient. Why would you not want that?
Right, absolutely. I mean, I know, like, Dr. Pita T is not super into A1C because he personally has a medical condition or genetic condition that means his A1C is not trustable, but even he says the difference still is trustable. If it was high and now it's lower, it means you're moving in the right direction.
And plus he works out like crazy, and so he works out like crazy. So that's 2 reasons why his A1C might not be completely accurate, but it's still going to give you a great tool to watch the trend.
Right. Yeah. The trend is super important.
Big time.
So a lot of the level I tend to say you should be very concerned about your A1C number is over 5.4. What level do you set it at?
Yeah. And so the reason it matters, because here's why it matters. There was a study done on veterans at the Veterans Hospital in Memphis, Tennessee, and they watched veterans who had an A1C from 5.6 to 6.4, which is pre-diabetes. And lo and behold, those vets, even if they didn't develop full-blown type 2 diabetes, 5, 10, 15 years out, guess what they started having? Kidney failure. It's like, so even though they haven't been diagnosed with type 2 diabetes, they only had prediabetes, damage is still being done. And if damage is being done in the kidneys, it's being done everywhere else in your body. And so I tell people, if your A1C is even 1/10 of a point high, if it's 5.7, you're pre-diabetic, you're doing permanent damage that cannot ever be taken back. You got to get that under control. And so I love an A1C under 5.5. But if you're under 5.7, I'm happy. But yeah, I'd much prefer to see a 5.3 or a 5.2. And I have patients now coming in with 4.8s and 4.9s, which makes me really happy.
Konstantinos would like to know, should fasting insulin be part of the general panel people are looking at, doctors are ordering?
Yeah. So if you're a pre-diabetic or a type 2 diabetic, or fear that you might be, then you want an A1C or a hemoglobin A1C check. You want a C-peptide check, and you want a fasting insulin. You want those 3 tests. Now, I check lots of other stuff, but that's just the 3 that I would use to keep a very close eye, not only on your glucose metabolism, but also on your insulin metabolism, because they're connected, but they're really two separate things.
Yeah, absolutely. One of the things that I've seen over the course of my ketogenic diet and many other people's ketogenic diet is just that fasting insulin number, boom, 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 coming down, down, down.
Yep.
And that makes such a difference.
Yes, absolutely. It's a big deal. It's very important because I think Jason Fung says it better than anybody. High blood sugar is going to cause damage. Yes, absolutely, without a doubt. High insulin levels are also going to cause damage, without doubt. And that's what the DCCT trial and the Accord study showed, is that when you nail somebody with insulin, you're causing damage as well.
A couple of people have asked about berberine versus metformin. Berberine being a non-prescription drug,
right,
like a supplement.
Berberine is to metformin as red yeast rice extract is to statins. It's basically a natural substance that does the same thing. And so for many people, berberine can actually help you more with your insulin metabolism than glucophage. The only problem with berberine is that it's probably not regulated as tightly, and so the dose might vary from capsule to capsule. It might not. Now, I'm not saying it does, but it might. And that's what every doctor is going to say is, yeah, but just take glucophage because you know the dose is going to be consistent. But effectively, they're the same thing. They do the same thing. Just like red yeast rice extract is basically just a natural statin. And so you can take Lipitor or you can take red yeast rice extract. It's basically doing the same thing in your body.
Right. Okay. Somebody has asked about weight training. I know you just started weight training.
Yes.
More significantly because you're 50 now.
Yeah.
Oh, sorry, Leslie, berberine is not the same thing as bergamot.
Big difference.
Not the same.
Bergamot smells better.
Yeah, you just started weight training. Someone is asking, what is the effect of weight training on A1C?
That's a great question. And so you guys know, hopefully you know, that exercise is a terrible method of weight loss. But if you're insulin resistant or pre-diabetic or type 2 diabetic, working out and building muscle is an excellent way to lower your A1C, to lower your blood sugar, and to lower your fasting insulin levels. It's great for that because the more muscle you have, the more places your body has to stuff the blood sugar. And your muscles use glucose. They can use glucose or they can use ketones, right? And so when you've got a high blood sugar, your pancreas ramps up insulin production and you push that into the muscles, they just burn it up. And so it's not really dangerous, right? But if you've got so much blood sugar that you start pushing the glucose into your liver cells and into other cells, that causes glycation, which can cause some bad problems. The retina being a great example and the liver being another great example. And so the more muscle you have, the more places your body has to stuff the glucose, which is a very good thing.
Got it.
And so it can really help lower A1C and control blood sugar for a type 2 diabetic. The more muscle you have, the better.
Also, just general health outcomes, more muscle, better metabolic rate, longer living, better bone density, survivability as you age. It's just across the board a good thing. Yeah.
It's a good thing across the board to have more muscle rather than less muscle. And I'm not saying you have to look like Danny Vega. I'm just saying you need more muscle than you probably have now. You will live longer and you will live better if you have more muscle on your body.
Right. Absolutely. Mm-hmm. All right. Any other questions people wanted to ask? Someone has just asked that they have an A1C of 5.4. Should they worry about that?
No, you should be proud of that and keep it right there or lower.
Right. So I will say from my history that when I got an A1C that was, trying to remember if it was 5.6 or 5.7, I did freak out because I was like, why is that is too high? And I talked to my doctor about it and she was like, yeah, I really am happy with A1Cs under 5. Luckily I had a good doctor who cared about this topic. And so that was like a turning point for me. So I think having an A1C of 5.4, I might have an awareness that I am okay, but I am closer to the edge of not okay than I maybe want to be.
Right.
And just
All
have
this
an
is on a
awareness.
spectrum. Yeah, it's
Right.
all on a bell curve. And so if your A1C is 5.6, right?
Yeah.
Then you're not doing much damage. You're still probably doing a little damage, but it's just a little bit. And so it's probably fine. You can still live to be a very, very old person with an A1C of 5.6. As that goes up, more and more damage is done. As that goes down, less and less damage is done. And so I would say that 5.6 is a great goal to get to if you're pre-diabetic or diabetic. But then you would still want to keep tweaking and playing until you got that down even lower. And there are actually doctors now, Kim, I've had people come to me and say, hey, I went to my doctor and my A1C was 4.9 and my doctor told me that that was dangerous, that I needed to eat more carbs. Literal quote from a doctor. And that, like, if a doctor says that, you don't even try to talk to them. You just get up and if you can shake their hand and not be rude, do that and never go back to that doctor again because they do not understand type 2 diabetes in the least. There was a study done in the U.S. that was partially funded by the drug companies that showed that there was a U-shaped curve of all-cause mortality. If your A1C got too low, that your mortality actually started to go up, partially funded by drug companies. There's a big study that was either done in the UK or the European Union, huge study that showed that absolutely as A1C went down, all-cause mortality kept going down. Like even down 4.7, still mortality was super, super low. Like you almost can't kill somebody with an A1C of 4.7. And so,
are there any conditions that cause very low blood sugar that might have confounded that U-shaped curve?
Maybe, but I doubt that's what confounded it. I think that the drug money is what confounded that. Yeah, that's what I think. Cause I'm a common sense fella, you know, I'm a country boy. If it smells like chicken shit, it's probably some chicken shit somewhere.
All right, that makes sense. And there's a certain point at which your body won't let your A1C go below because
that's right.
Your body makes all the glucose it needs, even on a zero carb diet. So there's a bottom.
There is. There's a bottom. You're not going to ever go too low to where it's dangerous. Your body will not let that happen. Your body's very smart.
Right. I guess to my point, just bringing this up that somebody that was just asked about, you know, should I be concerned about 5.4? I think my concern about, you know, a 5.6, 5.7 was I was like, geez, I'm only 40. What's it gonna be when I'm 60?
Excellent point.
So I think has to be a age to A1C awareness and what's your trajectory? Because that matters a lot.
Because as we get older, all of us, without exception, get more insulin resistant as we get older. And so my 50-year-old self is more insulin resistant than my 40-year-old self or 30 or 20-year-old self, just at a baseline level. And so if you're a 5.7 right now at 30, 40, or 50, what are you going to be in 10, 20 years? I think that's a very excellent point. And so if you can get it down lower now, that's very reassuring that you're going to be able to keep it at least within normal limits as you get older.
Right. Absolutely. Okay. A couple of people have asked about autism. I know that's not really your specialty. What do you think about some of the claims that a ketogenic diet is helpful for management of certain issues that come up with autism?
I think it's absolutely valid. I've got 3 or 4 autistic patients, and all of the parents are on board with keto, and a couple of them will supplement their child's diet with exogenous ketones, which I'm also in favor of if you have a brain condition that you just can't understand the rationale of eating keto. And so if anybody's ever worked with autistic kids, if they have severe autism, trying to make them do something is it's just a fight, and your cortisol level is going to be sky high. And so in that case, I think it's fine to try to slip some exogenous ketones into their cereal and milk or sprinkle it on their goldfish crackers or whatever. But if you've seen the magic pill, you've seen the power of keto and how it can affect autism. It's hugely powerful. And if a child has a seizure disorder, ADD, ADHD, autism, oppositional defiant disorder, anxiety, depression, any of that stuff, you need to move them lovingly, slowly, but surely towards a ketogenic diet. It is going to help their brain function either a little bit or a lot of bit.
Yeah, absolutely. Okay. Well, I think we'll wrap it up for the evening. I apologize if I missed anybody's questions. Sometimes they go by a little fast. So, thanks for joining me, Dr. B.
Absolutely. It's always my pleasure. And you guys watching this, share. Do they have permission to share this? Can they share this in their keto groups? They can.
Absolutely.
Okay.
Yeah.
So you guys share this because there are people who just don't know what we were just talking about. Only way they'll ever find out is if you share this video.
Absolutely. Thanks so much, guys. And if we didn't answer your question, we'll be back next week. And when I open it to questions, jump right on and say, what about this?
Yep.
Right.
I love it. See you next time.
Thank you so much for joining us on Keto Life Support. If you'd like more, you can join our friendly Facebook group, Keto Life Support. Can't find it? Go to ketolifesupport.com. If you ever want to suggest a topic for discussion, that would be the place to do it. We'd really, really appreciate it if you would go to your podcast app and subscribe, because that's awesome. And what would be super awesome is if you'd be so kind as to write a review for us. Though we would love it if that review was awesome, just writing a review is all we ask. So have a fabulous keto week, and we'll see you next time.